Part of our work with the ECRI-Penn Medicine Evidence-Based Practice Center, we recently released a report looking at clinical algorithms and the effects they can have on racial and ethnic disparities in health and healthcare. We're here with Kelley Tipton, the Associate Director of Clinical Evidence here at ECRI, to get into some more detail. So Kelley, as part of our ECRI-Penn Medicine Evidence-Based Practice Center, we recently released a report on clinical algorithms and the impact on racial and ethnic disparities in healthcare. Can we start with some basics? What is a clinical algorithm?
So for the purposes of our review, we considered healthcare algorithms to be any mathematical model or formula that would combine a series of input variables, and these would inform a calculation or an estimate. And so that might be an estimate of a disease, or it could possibly be the estimate of the risk of a particular health outcome. Now, what we also considered and included were algorithm-informed tools. So these might be things such as a clinical practice guideline. They possibly could be a clinical pathway. Now, what's important to note here is that we didn't include all clinical guidelines, but those that had recommendations that may have been based on an algorithm were considered for inclusion in our report.
How are considerations like race and ethnicity considered in these algorithms?
So algorithms are including a series of input variables. And so, as mentioned, they could be different. They're informing a calculation or a risk. These variables could be clinical variables, such as someone's blood pressure or a person's height, but they also might be socio-demographic variables, such as race and ethnicity. Now, more recently, clinical algorithms, healthcare algorithms, have been scrutinized for their use of race and ethnicity as an input variable. And there are a couple things to point out here. The inclusion of these variables can often be justified in a way as an effort to try to improve the accuracy of a given algorithm, so when trying to diagnose a disease. But it's also important to note that race and ethnicity are socially defined variables, and so they are thereby poor proxies for someone's biological markers or their genetic predisposition. With this in mind, using race and ethnicity in an algorithm that can influence clinical decision-making can have a wide range of effects. So some of those might be desirable, some could be harmful, but in a lot of respects, many of the effects are unknown. Part of our process in this review, which is important to point out because in the very beginning, we thought about limiting the inclusion of algorithms to those that explicitly include race or ethnicity. However, what we learned from our discussions with our experts and national experts to inform our process is that there very well may be algorithms that do not include these variables, but could potentially exacerbate or perpetuate disparities. So ultimately, the team collectively just decided that we need to include all algorithms that had any effects on disparities.
So what were sort of, I know this was a big and in-depth report, but what were sort of the top line findings?
So part of the top line findings is what we were really looking for is number one, what is the effect of algorithms on racial and ethnic health and healthcare disparities? And then number two, what can be done to mitigate racial bias within the algorithm themselves? What we found collectively is that there are several algorithms that are perpetuating and exacerbating disparities. And this had been previously mentioned in some seminal articles that were published ahead of our review. But two other important findings that we identified was that number one, algorithms may have the potential to reduce disparities. And in some of these cases, what it seemed to be is that the intentionality and the implementation of the algorithm can really make a difference or can really matter in that respect. Well, what we also found, the second thing is that algorithms that do not include race or ethnicity can impact disparities.
So you mentioned two key questions that we're looking at in this report. For the first question, can you give an example of how this would actually affect care for a patient?
Yeah, absolutely. So again, this first question, what are the effects of algorithms on racial and ethnic disparities? The evidence base for this was heterogeneous, and it's suggesting that algorithms can do one of three things. They may reduce disparities, and an example of this is that a patient may be in need of an organ transplant. And allocation scoring systems are usually used to triage these decisions. And so there were two examples of studies that implemented changes to an allocation scoring system. One of these tools was the revised kidney allocation system, which includes race, and the other one was the lung allocation score, which does not include race. And so what both studies found is that Black patients were initially more likely than white patients to either be on the wait list or to die on the wait list. Now, after these tools were implemented within these studies, the disparity between the two groups was reduced. Maybe some reasoning behind that could possibly be the fact that these tools were looking to either tackle some racial, ethnic, known disparities in health and healthcare, or possibly to standardize care in a way that would make things, that would reduce a disparity between groups. Now, algorithms may also perpetuate or exacerbate disparities. And so the majority of studies within this category, they were related to triage and care for patients and demonstrated that disparities were perpetuated or exacerbated. What's important to note also here is that none of these algorithms included race or ethnicity, but the studies all found that in these cases, non-white patients, which were mostly Black patients, were systematically deprioritized for care or systematically downgraded for resources. And so in this respect, maybe some of the takeaways here and that we could probably try to better understand is, are these tools being used in the context in which they were developed and designed? And then lastly, we identified a study that spoke to the fact that algorithms could potentially have no statistically significant effect on select outcomes. And in this case, this was an algorithm that did not include race, and it was used to triage acute chest pain in an ER setting. And what they found is that there were no differences in select outcomes between white and non-white patients. So what they found is that there were no differences in outcomes between non-white and white patients, but also they found that the adherence rates by clinicians to using this algorithm and this pathway were similar in both groups after the implementation of this tool. But what was interesting is that there were some differences in rates of adherence to the pathway by clinicians when patients were women. And so this may speak to maybe some of the pragmatic or the real world challenges with actually implementing and adhering to a guideline.
And then how about for the second research question for the review?
So this second question, yes, this is the one where we were really trying to understand what can be done to mitigate racial and ethnic bias in algorithms. And so what was identified were several different strategies. We identified 7 of them, 7 different approaches that have been used in studies to mitigate disparities. Some of them include removing race from an algorithm, possibly adding race to an algorithm. Some studies may have created a separate threshold for subpopulations to improve the performance of that algorithm. The most common approach was to remove race from an algorithm, and this was predominantly used in studies for EGFR, which is the estimated glomerular filtration rate, and this is used to measure kidney function. And so, most of the studies in this category that remove race from the EGFR found that the accuracy of kidney disease diagnosis and classification was improved. And so this would possibly translate into earlier eligibility for kidney transplantation for Black patients. However, there were other studies that also removed race from EGFR, and they found that the removal of this variable may reduce access to medications such as chemotherapy, or possibly reduce the eligibility of Black patients for clinical trial enrollment. And so collectively, the evidence base for this question outside of EGFR also included some other clinical areas such as measuring lung function or trying to determine cardiovascular disease risk. Across the board, we kind of take away that there may be these trade-offs in outcomes that really need to be considered. So, for example, an algorithm may improve the outcome in one way, but have some undesired effects in another outcome. And so with that in mind, maybe there are some value judgments that need to come into play to help determine what's really the most important and desired goal in patients in the use of the algorithms.
So there's no sort of straight line, just yes, include race and
Right.
ethnicity, or no, do not include race and ethnicity. It's a mixed bag.
So yes, to your point, Paul, it's definitely a mixed bag of information. But our review, this systematic review, really was a comprehensive assessment and early first look at the current state of healthcare algorithms and their effects on racial and ethnic disparities in health and healthcare. Some of the limitations, though, centered around the design of the studies that we used. Most of these studies did not actually use the algorithms in patient populations. Instead, they theoretically applied an algorithm to patient data sets to really determine what possibly could have happened had the algorithm been used. And so, therefore, findings across the key questions are highly context specific. And there are many factors to the types of patients that were enrolled in the studies, the clinical conditions that were assessed, and the clinical areas of interest. It may have been the outcomes that were determined to be important for a particular study. And so we really caution determining any type of causality about the algorithms and their eventual impact on the outcomes that were measured in these studies. But it really does help to give a picture of that current state.
So if I was a provider using these algorithms or the pathways that have the algorithms built in, and you mentioned there's sort of a group of them that explicitly have race or ethnicity as an entry data, but there's some that don't. If I was using one of the ones that doesn't, would I even know that there's an effect here on disparities if it wasn't sort of explicitly a data point that I was entering?
I think that from our conversations and discussions with our national experts, that providers, and that's more of an encompassing term of clinicians and systems and hospitals, are familiar with algorithms and how they can be used effectively, and that the frontline staff that are interacting with patients day to day are using these quite frequently. To your point, though, I think that the understanding about what really is within that algorithm to development life cycle, as far as how inputs are selected, what inputs are included in a given algorithm, what's that overall intent, what do those variables represent, even how was that algorithm tested and what patient populations were used to determine the efficacy of the algorithm. I think there may be some more limited understanding in those respects. And I think that may be applicable to algorithms that both include these variables, but also that do not include the variables. And I think it's important that this awareness is there because healthcare systems are increasingly deploying algorithms within systems such as electronic health records. So being aware of some of those limitations and understanding would be important.
So I've seen some news coverage that there are some professional societies and so on who are revising their clinical guidelines, their algorithms, as a result of work like this to try to focus on, obviously, not making disparities worse. That can take time to test, disseminate, be adopted throughout the healthcare system. What can providers do in the meantime if they've got the tool in front of them, they know there may be some of these limitations, but they don't have a replacement yet?
Yes, absolutely. There are things that can be done. I think one of the key items is to work to create these diverse research and leadership teams within those systems, within those practices, to really start evaluating algorithms that are currently in use, taking a look at what's under the hood of what systems are using in their day-to-day practices, and being able to try to make some evaluations about the impact of the algorithms on different racial and ethnic populations. And this can be done for, as I said, those that are in use, but also future algorithms that are possibly up for consideration and implementation within a system. Additionally, I think the piece of engaging voices at the table, even beyond the healthcare providers and systems, including those who are affected by algorithms, so our patient communities, our advocacy communities, and having those voices at the table to really better understand what's happening with the algorithms, how is it affecting the world of healthcare, and ultimately patient outcomes. And then lastly, I would say with the increasing deployment of algorithms in different respects It's that awareness about maybe the underlying evidence for a given algorithm and how it's being used in one center versus another. Understanding some of those, intrinsic attributes of a given algorithm that could potentially lead to bias or improve disparities. And so I think there are a couple of ways that providers can be involved and start having these conversations and taking some real action.
Kelley, thanks so much for being with us today.
Thank you. I enjoyed it. I appreciate you having me.
Thanks for watching ECRI Now. You can find more insights from the experts on YouTube and at ECRI.org. Until next time, I've been your host, Paul Anderson.